My name is Jill Swartz. I'm honored to represent PRP Science and Specialty Med Training and feel privileged for this opportunity to bring together our panelists for tonight's educational collaboration, Dr. Peter Everts and Dr. Joseph Bano. Dr. Peter Everts, who has a PhD actually in PRP, is well known as the father of PRP and has spent his career dedicated to the study of autologous biologics. And Joseph Bano, who's a board certified urologist in practice for the past more than 30 years, and who's been using PRP and recently now shockwave therapy in his clinical practice for the last several years with great success. So tonight's webinar is really an opportunity to bring some education and awareness to the related science and the new applications and techniques for these latest regenerative therapies. I want to let you all know that we're going to close this presentation in 45 minutes. So we're going to try to finish about 8:45 so we can leave some time for Q&A. I also want to let you know that you are welcome to post questions throughout the presentation. Due to the detailed content that we're going to present tonight and the live presenter interaction format, we will allow, this short time for Q&A, but I do want to let you all know that we are going to extend a special invitation at the end of tonight's webinar for all the attendees and registrants to really get up close and personal with Drs. Bano and Dr. Everts at a live lecture that we're going to be hosting in Miami on June 13th. I'm going to share all those details with you at the end of tonight's presentation. I also want to just advise you all that there's handouts that are available for you to download, and in this presentation you can see the handouts on the right hand side, and as well these are about 5 handouts that are relevant to this presentation, but we have tons of studies and other research handouts that are available for download at specialtymedtraining.com and prpsciencemd.com. Okay, so without further ado, I'd like to introduce Dr. Peter Everts to take control. Dr. Everts, are you there?
Yes, I'm here, Jill. Thank you for your kind introduction. Good evening, everybody. First, before I introduce myself, I would like to introduce you to Dr. Joe Bano. Joe, are you with us?
Yes, I am. Good afternoon, Peter.
Good afternoon. Please give us a little overview of your extensive career, and then I'll take it over with my introduction. Joe.
Okay, so I've been a board certified urologist for the last 35 years, and my special interest has always been sexual dysfunction. And starting 5 years ago, I noticed an article in the Journal of Sexual Medicine dealing with platelet-rich plasma and rat studies, and it really gained my interest, and it sparked it with another one with stem cell studies. And so I was fortunate enough to be one of the early people involved in platelet-rich plasma. Thanks to the, I'd have to give a big shout out to Dr. Charles Reynolds, who took it from the animal study to the human studies and has made terrific gains with it. And I have been involved for the last 5 years with platelet-rich plasma, and for the last year and a half with shockwave therapy. I've recently combined them, and so sexual dysfunction is very near and dear to my heart, along with hormonal balance.
Thank you, Joe, for that. I'm Peter Everts. I'm currently the Chief Scientific Officer for MSite Corporation and the Program Director for Gulf Coast Biologics. And Gulf Coast Biologics is the educational and scientific center for MSite Corporation. I was asked a while ago by Joe and by Jill to join them in this webinar, and like Jill mentioned, I've been working with PRP and stem cell therapies since the early 1990s. And I was lucky enough to spend a lot of time in the lab working with animals, and ultimately have sufficient proof for the work and the research I did, including clinical studies, to acquire my PhD at the University of Utrecht. This is just a picture of how formal the entire procedure is. On the left-hand side, the young guy looking to his right would be me just prior to the moment to defend the thesis for an entire committee. And that actually was, for me, the start to have a more in-depth view on, well, what kind of position could PRP therapies take in modern medicine. So I came up with this slide in order to create some positioning as where we are right now. So very recently, only less than 10 years ago, we started to have a serious look at adding a different therapeutic tool to the entire arena of medicine. So we are all aware about surgical activities and anything that has to do with it. Medicine, the pharmacological field has been well addressed. And again, very recently, we only discovered that biologics could enter in that arena by using cells, and therefore we came to the definition of regenerative medicine. And the key thing here is that cells are actually the key. Cells which we have in our own body and in the whole blood, in the bone marrow. You're going to address that a little bit further. And that's how, and I challenge you for that, some definitions have been created on, well, defining exactly how regenerative medicine could be termed. I came up with this definition when I looked into a lot of articles, and the main things I would like you to take is that regenerative medicine is indeed a new, but it's science-based medicine, and in a lot of cases we work together with a lot of different specialties. And the key thing here is we use the patient's own stem cells, and we use patient's own growth factors. We can work with patient's own tissues, and the goal here is to repair and to restore healthy function of tissues. And at the moment, we have a lot of clinics and a lot of organizations teaching aspects of regenerative medicine. And actually, more and more centers really have adopted, what we call focus clinics, have adopted the use of regenerative medicine technology in big universities. You can see here on the slide, and they're all contributing at the moment to further develop and steer where regenerative medicine could go. So for now, I would like Joe to take over and see where he envisions the future of platelet-rich plasma urology, Joe. So Joe, you came up with this slide, did you?
Yeah, I did, because I've probably treated 600 patients with platelet-rich plasma, and for erectile dysfunction, I really found that patients who were responders to the PDE5 inhibitors such as Viagra and Cialis, who no longer became non-responders, these were ideal patients to use platelet-rich plasma for, and very high success rate with these individuals. Peyronie's disease is a condition that I'm seeing more and more, and other ED specialists are also seeing this. And through my practice, I've been seeing terrific results in making the plaques actually disappear and making the curvatures less. And I've been documenting this with ultrasound. before PRP came along, I only had Viagra and Cialis and penile implants to offer patients. And some of these penile implant patients, they had a decreased sensation following the surgery. So I was able to use platelet-rich plasma in the glans penis and bring back their sensation. As far as women goes, women with overactive bladders and female stress incontinence have really responded very well. Women who've had pelvic pain and vaginal atrophy have also responded to platelet-rich plasma. So, you know, these are some of the areas that I've been treating in my practice and having very good success with these patients. I have an interesting, you know, patient who really had to have his penile implant removed, and I was able to use platelet-rich plasma on him a number of times, 3 to be exact, and he was able to gain some sexual activity back where he had no sensation at all. After the second injection, he started getting sensation back, and he was able to, you know, expand his penis in such a way for some satisfactory sexual activity. So it was in these early cases that when the 2000 study right here that really sparked my interest way back when, this study showing that the erectile function improved and it was shown in the Michael architecture of the corpora cavernosa. This study came along with another study in 2012, which showed the neuroprotective effect of PRP. And this is where rats underwent radical prostatectomy and nerve injury to the cavernosa nerves. And it showed that the nerves, the rats that were treated with platelet-rich plasma returned their function back, as opposed to the rats that did not receive platelet-rich plasma. So this is another study that was followed the initial study in 2012 from the Tissue of Engineering Regenerative Medicine, again showed the effect of platelet-rich plasma restoring erectile function in rats after they had radical prostatectomies. So this was a pilot study by Charles Reynolds in 2014, which the preliminary results of the pilot study suggest that intravaginal and intraclitoral platelet-rich plasma could be effective in certain types of female dysfunction, especially in lubrication, vaginal atrophy, and dyspareunia.
Good, Joe. Yeah, what you see here is the definition of autologous platelet-rich plasma as being mentioned in here. And I just want to take a couple steps back and talking a little bit about the essentials of platelet-rich plasma. And really, we need to go back to our textbooks and get an idea on the definition of whole blood, as whole blood would be the starting point for preparing platelet-rich plasma. So you see all the main components of the blood with red cells and white blood cells, a variety of leukocytes and platelets. And I tell physicians, if you want to have an idea what these machines nowadays can do, is just take a vial of blood, put it in a vertical position as you see it on the slide, and leave it there for 45 minutes. And just based on gravity and density, you will have the occurrence of the various layers that are naturally in the blood, and each of these layers have specific cell contents. And actually what we are doing with the preparation of platelet-rich plasma is that we literally gonna stick a needle in a patient, we do a phlebotomy, we have access to a good vein, we have then a syringe that has been loaded with anticoagulants to prevent clotting, and that syringe, if we would like to put it on a microscope on a blood smear, that would be this look at this figure. So you see in the circle, you see some small blue dots. That would be platelets, and then you see some darker blues. That would be the white blood cells, and the bigger light blue ones would be the red cells, and the white would be just fibrinogen. So any machine that is called a PRP device, and then this is just an M-site centrifuge for conveniences, and because I know the machine pretty well, we'll go into the steps a little later, but ultimately after a procedure of having the blood spun into the machine, you will have a completely different aspect. This is what's going to look like when you have completed a procedure. You do a blood draw, you process it in the machine, you follow the instructions for use from the manufacturer, and ultimately you have prepared platelet-rich plasma. And as you can see here, all these dark small dots are a high concentration of platelets in a very small volume of plasma. So when you compare the left and the right, you see a tremendous increase in platelets with a small volume of the plasma, and a significant increase as well for the white blood cells. So what's the magic? What's the rationale for platelets? So normally they are in this shape as they're circulating in the blood vessels. They really circulate without anything happening to the exchange of fluids, of contamination or whatever. But once platelets become activated, they start to release their entire content. So the platelet, as you see it here in the picture, will start to change its shape, and we'll get back to that at the later moment. But ultimately, the goal here would be that platelets will release the so-called platelet growth factors. And we know about many platelet growth factors, and this here is just a summary of the most important ones. And especially if you are interested in sexual wellness, ED, then a couple of these growth factors have high significance, especially like the one on the right hand, the vascular endothelial growth factor, transforming growth factors, because those are well recognized from literature on neogenesis and angiogenesis. So you would like to have those at a significant concentration available in your product when you do the injections, so that high concentration of these growth factors have the ability to build blood vessels. That's not the only thing that's happening inside the platelets, so I call them therefore the so-called platelet secretome. It has a lot of things in there, like the growth factors, but also a lot of other proteins, and they all have the specific function, and that's the beauty of it. What we do is we take the blood sample, we concentrate it, as we call it, and we make sure that we have that same balance as in the native circulating condition, where platelets and other proteins work together. We're just going to increase these so-called cytokines and chemokines as well. Then what's important to consider is, do we think there's a role for the white blood cells in there? As you know well as I do, the literature in PRP only started very recently to understand, well, the importance and the contribution of the white blood cells, what they have with regard to healing. So we are still working at the moment in all speaking the same language. So when we talk about leukocyte rich, I will talk about leukocyte poor plasma, and physicians really have that option in understanding well, not only what the importance is, but also what kind of a formulation, what kind of a composition you would like to have. So, as you know, I'm just summarizing some of the textbooks from a while ago. All these white blood cells, they have their specific function. What's important to notice is that after a procedure in the centrifuge, both the basophils and the eosinophils are not going to survive the centrifugal forces of the centrifuge. So you're left with the neutrophils, with the monocytes, and with the lymphocytes as being part of that platelet-rich plasma volume you have. And that would be the general definition to it. And we started to look into, well, what's important? Why is it important? Are they important? And we get more and more consensus that the white blood cells are important and they do have a function into wound healing and into immune modulation. So we really are in favor of them. For certain areas in medicine, like orthopedics, where you do not want to have a severe inflammatory response, we are able to remove the neutrophils in the product. So we have some flexibility as well in creating that formulation. And again, these are just a couple of branches that are out there. There are about 25 to 30 machines. And well, they all have their different characteristics from a design perspective, from a protocol perspective. And as you can imagine, they also differ for those reasons in getting a different product for you to work with. So we're not going to go into it right now because the idea of tonight is just to share information, to exchange knowledge, and it's for sure, well, the most important goal for the night, instead of having, well, let's say a sales pitch here for one of the other devices. But the main thing I would like you to take is that the PRP by itself will have different aspects, will have different phases. And there are sufficient papers out there really stating that is important to understand, well, what kind of a PRP you're working with, and especially also with some of the white blood cells like the monocytes. I think monocytes are great. Monocytes are being made in the bone marrow. They leave the bone marrow into the circulation. And once they reach the circulation, they turn into macrophages, and they have a significant contribution into regenerative medicine aspects. Another important thing for you to understand is that for whatever indication you would like to use platelet-rich plasma therapies, again, you should be able to work with different PRP formulations. And based on the medical field you're in, you have different treatment goals. And if you have different treatment goals, you have different ways of distributing the PRP to your area. So I'll just show you a couple which I like. This will be for a patient with a chronic wound, so you can produce a so-called PRP topical graft you can apply to a wound. You can use aerosol-driven PRP, so it's sterile spray mist, so to speak, with platelet-rich plasma for wounds, surgical procedures. You can just do a single injection, like here in the knee. You can inject it into wounds, or you can combine it with, in this case, adipose tissue and mix it as a graft. So you have a lot of options here as how you can apply it to, well, to your individual situation. Before I hand over the next slide to Joe, what I would like to do here is, and we'll go over to it in a little bit of depth, but what I meant a couple minutes earlier with regard to formulations is that any of the devices in the market, they should be able, based on what the literature is indicating, based on the experience of what kind of a regenerative medicine, autologous biological product you would like to use, you should be able, following the literature and applying using a PRP that has a certain composition. And a little bit down the line, I'm going to show you that when you are able to distinguish what kind of protocol you would like to use, you are able to deliver these growth factors out of a whole blood sample into an area that you would like to use, and have therefore these particular cellular components available for you. So Joe, yeah, this is one of your slides, and you concluded already a while ago. You came up with the same idea that all PRP is not created equal. Would you like to quickly recap on that?
Yeah, I think it's great that you explained to the participants that all PRP is not the same. And as a matter of fact, even in Peoria, Illinois, there's a podiatrist who was using PRP about 3 years before I was, and he had a 92% success rate in treating diabetic foot ulcers, and it was just amazing. So it's important really to have the right equipment for the right problem that you're attacking.
Perfect. It's great well, to hear that you already discovered it in your experience over the last years.
So this was a small retrospective study that we did early on, and it showed 90% of the patients studied either improved or stayed the same, and more importantly, there were no adverse side effects, and 100% of the patients recorded no side effects whatsoever, and this study was statistically significant. So again, you know, when you talk about platelet-rich plasma and the patients answer subjectively, oh, I feel much better, my penis is more erect, I'm getting nighttime erections. Well, we have to show, you know, being specialists, we want to see data and results. So when prior to evaluating a patient, we obtain penile duplex ultrasounds. So we measure the arterial velocity and the venous outflow. And this was a patient who was 52 years old, had hypertension and diabetes. And you can see that he has venous velocities of around 80 cc's per second. And the venous outflow was around 20. He received platelet-rich plasma, and then 12 weeks later, we did a study in the next slide, which actually showed the arterial velocity improved to 114 centimeters per second. And here's the thing, the venous insufficiency decreased from 20.5 down to 7.5. Remarkable. And he was having great erections. He could resume intercourse. He hadn't had sexual activity in 5 years previously. So these are the kind of studies that we like to show objective criteria, and by use of the IIEF form, a validated questionnaire for erectile dysfunction. Those are two of the most important tools that we use to show objective improvement. So in male sexual dysfunction, you know, we're going to talk about the patients who have had, you know, problems. The main patients that I see are patients who have diabetes, hypertension, and cholesterol disorders. You know, back in the 80s when I was at the University of Chicago, we believed that most of this was psychological and 10% was only organic. But now we find out that it's 80% organic and 20% psychological. However, as I tell my patients, even if the patient has carcinoma of the prostate, there's still some psychological barriers that you have to deal with. So the nerves have to function properly. The blood circulation is important. you know, that, and I think this is one important thing that we say now. So when clinicians are performing interviews in patients who have sexual dysfunction, we have to make sure that sometimes erectile dysfunction is an early warning signal that they may be having a myocardial infarction 3 to 5 years later. And again, the veins have to be able to trap the blood to keep the penis erect. Next slide. So what are the causes of Peyronie's disease? We can see this with, it's associated sometimes with Dupuytren's contracture of the hand. It was first described in the late 1700s. Scar tissue forms. Sometimes it's a Peyronie's light plaque can happen with a fracture of the penis. And you can have a severe curvature and still maintain an erection, or you can have a curvature with distal vascular embarrassment. And the bad thing about Peyronie's is there's a shortening of the penis. So I've had patients who've lost 2, 3, even 4 inches of their penis because of the severity of the Peyronie's disease. The pain is usually short term, but it can last as long as 6 to 12 months. And usually this stabilizes. So erectile dysfunction is a huge problem. You know, it's estimated that anywhere between 30 and 40 million Americans suffer from either mild or moderate, severe erectile dysfunction. And 57% of patients are in the 40 to 60-year-olds. So we, you know, this bullet point up here say ED can occur as early as 40, but I've really seen people recently in the last 10 years in their 20s having erectile dysfunction. And here's where the real problem lies, is that most clinicians do not want to deal with erectile dysfunction, and most patients don't want to tell their story. So I think that, you know, my job is working with medical students and residents is to get them to feel comfortable about asking the right questions. And so there's no question that, you know, as emerging therapies, you know, come about, you know, the advent of Viagra in March of 1998, you know, really brought this to a forefront, and people were willing to talk about it now. So traditionally, as I said, ED was treated by psychiatrists and psychologists, and with the advent of penile surgery, you know, urologists came to the forefront, and the penile implant was came about in the late 60s. And the inflatable penile implant is really a good device, but you know, many people want a non-surgical approach to something like this. So what do we do at our clinic? We talk about nutritional modification and exercise, always balancing, making sure that the testosterone is within normal limits. I think the vacuum erection device I've used for over 25 years in my practice as an exercise tool, using it to get blood flow into the penis on a regular basis. Clearly, the PDE5 inhibitors have really been a boon to getting people out of the woodwork, and it's helped them tremendously. Penile injection therapy first started in 1985, and it has been another way to regain sexual function. But now when we talk about platelet-rich plasma and shockwave therapy, these are entities that actually repair and regenerate and rejuvenate the blood vessels and the nerves. All of these other devices have or treatment options have really kind of masked the treatment of ED. But what we try to do with the nutrition and exercise is bring about a change in the patient's well-being. So with Peyronie's disease, I've seen 50% or better improvement in the curvature. We've talked about the decreased sensitivity that can occur with the penile implant, and so we increase sensitivity and blood flow, and we see firmer erections in patients who've had Viagra, and they've had it for 10 years, and now they become non-responders. And why do they become non-responders is because they simply take the medicine but don't change their life. So at our clinic, what we try to do is show them a healthier lifestyle. So, you know, everybody's experience with PRP is different. I think, as Dr. Everett said, you know, having the right PRP and the right system is important, but we see an increase in firmness with erections. We saw, as in the penile ultrasound, an increase in blood flow and circulation, a increased sexual stamina. Sensation becomes very important, and enhanced appearance, especially, as I said, people who have Peyronie's disease. When you treat these people and you improve the elasticity of the penis, they regain some of their lost length. So, you know, just recapping, platelet-rich plasma is a safe and effective if you're using the right concentration to achieve the outcome. You have to use the right equipment, and it's important how to utilize PRP. And I think you have to be honest with the patients. And, you know, I have a large sexual dysfunction practice, and, you know, PRP does not work for everyone. And I tell that in all my lectures. And I think that's why, you know, they have to know there's certain limitations, and that's why we do some of the early studies. So for female sexual dysfunction, I've been especially happy with what this has done for women in the area of urinary incontinence and vaginal atrophy. 43% of the women do experience some form of sexual dysfunction in their lifetime. 20% of the sexual experience are unpleasurable because of sometimes of pain. So we want to decrease the stress, decrease the depression, decrease the pain. We want to see decrease in heart disease, incidence of cancer. We want to have a sense of well-being. We want to increase their longevity. We want to see the women as happy as the men, because many times when I'll place a penile implant in someone or perform PRP on a man, you know, the woman will say, fine, you helped John, but what about me? You know, this you want to see a happy couple together, you know, experiencing, you know, the joy of good sexual function. So 40% of women have some form of incontinence, whether it's stress incontinence or overactive bladder. And these numbers increase with age. And I think that, you know, this one bullet point, incontinence is the #1 reason a woman is placed in their nursing home. Well, I've seen in my short span of being a urologist, I've seen people go from just simply putting a catheter in them to actually helping them with medication, surgery, and now with PRP. You know, we're helping people with stress urinary incontinence and overactive bladder. So some women who come to me, you know, simply say, this is my main problem. And you know, when you interview them and you ask more questions, you find out, oh yeah, I do have vaginal atrophy and it's dry down there and I lack the lubrication and sometimes it's painful. So sometimes you can treat all of those abnormalities with one PRP therapy. So this, what do we treat? We treat hypoactive sexual disorders. We, again, as with men, with women, we want to balance their hormones. We want to make sure they have adequate levels of testosterone and estrogen and progesterone. We want to make sure that if they have any sexual pain disorders and have dyspareunia, we want to make sure there's no anatomical problems to begin with. And we want to make sure that the lubrication is adequate for satisfactory sexual activity. So, you know, these are some of the same factors that cause sexual dysfunction: diabetes, hypertension, neurological disorders such as MS and Parkinson's disease, recurrent urinary tract infections, hypertension, smoking. And you know, that's one thing that we try to tell our patients. We get them on cessation of smoking programs, and naturally alcoholism and drug abuse. So what do we do with these female patients? Again, diet modification. Behavioral therapy is really important in overactive bladder. Medications such as Myrbetriq can be very effective. Botox for some individuals, surgery, stimulators, and platelet-rich plasma and shockwave therapy are what we are using now for some individuals. So again, every woman's experience is different than as is men's. So what do we see when we use platelet-rich plasma in the vaginal area? We see more frequent orgasms, increased desire, increased ability to have a vaginal orgasm, increased vaginal lubrication, a tighter vaginal opening. These are some of the things, and especially increased resolvement of their urinary incontinence. And this is both urge and stress incontinence. So low energy shockwave therapy, again, it was interesting, the fact that this is the same technology as shockwave therapy used with kidney stones in the mid-80s. And interesting also, in 2010, Israeli researcher Vardy came out with a paper where he was treating patients and was getting some early good results. And as we age, the blood vessels in men, in the penis, in the clitoris, they start to either obstruct or atrophy. And what shockwave therapy has been shown is that angiogenesis is increased. So we get a greater blood flow, a better arousal. And we even think that there's some improvement in the nerves. So I had followed this therapy even more in the early years than PRP. And I really thought that this would be, you know, FDA approved in 2013. But as of today, I use it in my office as off-label. So this was the study of Vardy, and he used a randomized double-blind study to show that again, people who were non-responders to PDE5 inhibitors became responders after shockwave therapy. So, which has led me to low energy shockwave therapy and the combination of platelet-rich plasma. So, we're in the process of performing a ongoing prospective randomized study comparing the combination of PRP and shockwave therapy to shockwave therapy as a standalone treatment. And the results are going to be analyzed using the penile Doppler ultrasound and the IIEF scores, along with the balance of testosterone. And what we're hoping to expect to find increase in both the venous flow, but the combination treatment hopefully is statistically significant with higher IIEF scores. And as a side, just an hour before I came on to do this webinar, a patient had called me up who had platelet-rich plasma injections in the past, and 3 weeks ago he had shockwave therapy and platelet-rich plasma, and he stated that the very first night he had good nocturnal erections, and he woke up with a very firm erection. And he said that this happened before with platelet-rich plasma, but with the addition of shockwave therapy, it happened sooner. So, Pete, what do you think about the combination of shockwave therapy and platelet-rich plasma?
I think it's a very challenging thought. As your slide showed as well, one of the objectives would be the ability to create new blood vessels to optimize vascularization. And that's actually where I would like to go with my next slides as well. What is important to understand is that the choice that you're going to make for a PRP device should ultimately fit a specific patient and a specific disease condition. In other words, you should be able to, well, to have sufficient cells available that going to work with the objectives of shockwave therapy together. So in other words, they're really going to enhance, at least that's one of the objectives, well, Joe mentioned as well for a study, is in having, well, devices that are capable of producing, again, different formulations, because the trick really is to understand, well, what is in your PRP, as we have learned that we have so many different PRP compositions. And on the right slide, you see the animation, you see just the distribution of all the cellular components that we have. And that's what these function of these centrifuges really are, is to bring them up to this layering composition. And once we have that layering composition, we can work with these cells, and that's ultimately, well, the basis we strongly believe, and we learned over time, to have a product that ultimately is going to make a difference. Just to take you for 2 minutes to the procedure, we choose to work with a device in which we have a 2-spin procedure. So on the left-hand side, that would be a container that had all the blood. And as you see, after 1.5 minutes of spinning, centrifuging, you see the nice separation of a clear plasma layer and a red cell layer. And what you could do, and really I support the idea, is, well, take some CBC work and really understand this on how the product is going to work for you, what your constituents are going to be. On the right-hand side would be the final step after you acquire, and at a later stage we're going to go through it in a more live situation. But ultimately, if we just forget about how it's going to be done, you will have a product available that you're going to work with. And what you see here is a product which we call the pure platelet-rich plasma concentrate, which has undergone all the steps in preparation. And what's capable of generating out of that whole blood sample, you will have again, that small volume of plasma, and it has a huge number of platelets in there. So if you calculated how many platelets you can deliver to any tissue site, whether it's a penis, whether it's for intravaginal indications, Peyronie's disease, you're gonna have a small volume you can inject. And again, depending on what you would like to treat, you have the ability to work with smaller volumes or bigger volumes. But the main thing is the amount of platelets that, due to the system configuration, you can capture is, in this particular case, about 6 billion platelets that you have at hand to deliver at a tissue site or have available for multiple injections. And based on the specifics of this device, we are able to reduce the neutrophil, so we are able to minimize the pro-inflammation significantly. We have a huge increase in monocytes, and monocytes are again well known for their regenerative capabilities. And also, what you do not want to have in an injectate would be a significant amount of red cells. So yeah, this would be the ultimate product for you to work with. And when you look at it, and based on, well, the choosing for this procedure, what you capture here in between these two black lines would be that volume that has that high concentration of platelets, monocytes, and lymphocytes for you to work with. And that brings me as well, Joe. So you are convinced that by using the product that has a combination of cells, that you are seeing in your practice accelerated repair and restoration of function, Joe?
Yeah, absolutely. And I think that you bring up the increase in monocytes, which I get from the enzyme system. It actually holds on to the structures within the corpora cavernosa to allow the PRP to really hold on for several days. And I think this is an important aspect of the pure PRP that we use. So we've actually seen patients that no longer require medications, and the pain-free following Peyronie's disease treatment. And interesting, and I've talked to a number of other clinicians around the world, and we really don't see any adverse side effects. I've seen no evidence of infection, and I've injected over really 10,000 patients, so since 1985 with penile injections to teach them. So I think it's a very cost-effective method. It really does repair and rejuvenate the vascular endothelial, and patients are happy that they don't have to go to surgery. They can see improvement in their erectile function, and they usually see it within 12 weeks. So again, there's some studies that are available, and I think these are available to all of you. They can be found on specialtymedtraining.com and prpsciencemd.com on those websites. And so I hope in the future that Dr. Everts and I can be presenting to you some of our prospective randomized studies in which we show that this platelet-rich plasma and shockwave therapy offers really objective criteria for the improvement of the patient's sexual function.
Thank you. I think that was the last slide. So we did it nicely on time. If from the audience people have questions, you're able to type them into the questionnaire box, and I really encourage you to download the handouts as well. So please go ahead if you have questions. In the meantime, I call the organizer Jill back for the last slide introduction.
Okay, thank you, Peter. Thank you, Dr. Bano and Dr. Everett's a fascinating presentation. And the response from all the attendees resonated that as well. We have put together a clinical collaboration for Dr. Bano and Dr. Everett's to continue this conversation because, in fact, we get so much feedback from providers that we extend this information to that says, oh my gosh, I'd like to learn more. So it's very difficult to create a venue or to locate a venue where people can find this type of information. So we've actually created this continuing conversation and a call for a clinical collaboration, and we're hoping to set up additional webinars, hopefully monthly maybe, where we can present different findings in the whole regenerative space. We're thrilled that Dr. Bano was able to present us with some urological therapies. Hopefully we are aligning ourselves now with other specialties that can help us bring additional information in their fields as well. But on June 13th, Dr. Bano and Dr. Everett are coming together. We're thrilled to have them in one place for an interactive live lecture. We will send every attendee to this, or every registrant to this webinar, further information about this. So with that, I think we conclude, and we are about 1 minute and ahead of schedule. So I'm thrilled that we were able to present this. Thank you again, Dr. Bano, Dr. Everett, for your time, your energy, and your expertise to bringing this information forward to the community. We are privileged to be able to hear this kind of information from you.
Thank you, Jill, for putting this together. It's very informative, and I know this has a very exciting future. So, Dr. Everett, I'd like to thank you also.
Thank you, Dr. Bano, Jill, for the organization. I'm looking forward to meet in a couple of weeks.
Great. Okay, well, hope to see you all on June 13th in Miami. Have a great evening. Thank you.
Thank you.
Good night.
Bye-bye.
Good night.